Well, good evening, everybody, and welcome here to the GUcast studio for this very special Mundipharma webinar. My name is Declan Murphy. I'm a urologist at Peter MacCallum Cancer Centre, and I'm joined here by my GUcast co-host, Renu. Oh, it's not Renu Eapen.
Come on. It's a better version of Renu here.
Normally I have Renu Eapen, the real talent behind GUcast, sitting with me here in the GUcast studio. And she's in the building, Ben, she's somewhere. But in the meantime, I've had to make do with Professor
I'm ready.
Professor Ben Tran, who is well known to the GUcast audience. Ben is one of our clinical advisors, actually, on the podcast. And of course, a GU medical oncologist, the head of the GU medical oncology team at Peter Mac. And you're on our panel tonight, but you've just got promoted to co-host.
I'm so excited to be co-host, talking about intensity of treatment. It's going to be a great night.
Did you always want your own podcast or your own stand-up comedy routine, maybe?
I've been working a stand-up comedy routine, but none of that tonight. Yeah, come on. This is a family-friendly show.
So some of you might have seen Ben in action at the ANZUP annual scientific meeting, where he did a wonderful stand-up after the dinner. So watch out. It's not in the schedule I can see, and it hasn't been pre-approved by Mundipharma. But Ben Tran, what do you call it? Unplugged?
It will soon be not co-host, the only host, Declan. Just watch out.
Okay. Anyway, so you're all very welcome. Thank you for dialing into this webinar. So the theme tonight is intensification of therapy in metastatic hormone-sensitive prostate cancer, the who, the when, and the how. So, of course, Ben, this is a very topical area in metastatic hormone-sensitive prostate cancer. No longer really, for the majority of patients, are we just doing ADT, or we shouldn't be. And what we want to do tonight is learn about the reasons why we should be intensifying it. This is the term, I think, intensification. So we're adding something to ADT. How do we select patients? How do we intensify? What agents? How do we use radiotherapy in these settings, and so on?
My message is going to be a physician, Declan.
Yes, like you.
Hey, like me.
So Ben's going to teach us to be physicians, and we have a very mixed audience. We know we have about 190, Kieran, or thereabouts, registrants. Kieran from Mundipharma is here in the studio. And we know it's a very mixed audience of urologists, medical oncologists, radiation oncologists, nurses, some nuclear medicine physicians, and trainees, of course, in all those specialties. So hopefully we'll all learn a little bit about that tonight. So our plan this evening, Ben, is to edutain, as we sometimes say on the podcast. We're going to educate, but we're going to try and make it a little bit entertaining. We want very much to have audience engagement. So unlike a normal GUcast where we're not live, we're just pushing it out on this webinar, of course, we want to hear from you, the audience. We want to have questions. And you'll see on the nice platform that Mundipharma have provided, there's an option to ask questions. I think it's over to the right of your screen. So we want you to ask questions. And our panel, who I'll introduce in a moment, will be dealing with those at the end of the podcast. And we'll keep pushing you to remind us as we go. And don't worry if we're not answering it straight away. We will get to the questions later on. And we also have some polls. So we want to hear what you would do with this patient when we get to our case discussion section later on. So the plan is we're going to kick off with me doing a brief talk about what I call the puzzle of metastatic hormone-sensitive prostate cancer. It used to be so simple. It ain't so simple now. Then Ben, you're going to do a bit of a talk about how we intensify.
Intensifying treatment.
Yeah, and these are short talks. We're aiming for like 10 minutes, just some, big hitting take-home messages. And then we'll be welcoming Professor Amy Hayden. Amy is a radiation oncologist at Macquarie University, associate professor there as well. And she's going to talk to us about the role of radiation to the prostate, really is what we're focusing on in our theme of intensification in men with metastatic hormone-sensitive prostate cancer. So Amy will do a talk on that. So we got 3 quick talks. Then we're going to have some case discussions. We'll present 3 or 4 cases. We'll have polling questions for you to get involved. And we'll invite our panel to discuss these cases. So on the panel will be myself, Renu, when she turns up, Ben, Amy Hayden, and our final panelist, who is Professor Louise Emmett, a nuclear medicine physician extraordinaire at the Garvan in Sydney. She's the director of theranostics at St. Vincent's in Sydney. So Louise will be joining us for the panel discussion. And of course, that's a key thing, isn't it? Because in defining metastatic prostate cancer, what scans do we use? What about PSMA, etc.?
Truly multidisciplinary.
Truly multidisciplinary, exactly. So a great panel, and I hope that you all learn a bit. I'm certainly looking forward to learning a bit. Learn to be a physician.
Learn to be a Declan.
Can you make it not too complicated?
Physicians for dummies.
Yeah, physicians for dummies. That's
dummies
exactly
for physicians. One or the other.
So, so what we'll do then, if that's okay, is I'm going to kick off, and I've got a quick talk that I'm going to speak about. Ben, I'm going to move you back to your chair for a second. Chat among yourselves there, Ben, while I change one of the settings on.
So I was wondering when the poll is for when. Are we going to do a poll on who should be prescribing these agents, Declan? Is that going to be part of the story today?
That is one of the hot topics, isn't it? Who should be in charge of metastatic hormone-sensitive prostate cancer? And we'll get our teeth into that. And I think the thing is, lots of us can be involved in this decision. You know,
it's a team.
And so let's do that. And this is GUcast. This is our studio here in Melbourne, in my house. Actually, this is where we push out all these episodes that we've been doing for the last 4.5 years. And we couldn't do this without the help of people like Mundipharma, who support us. There's an example of a podcast we did recently. This is on the EAU guidelines, and that was a very popular podcast, many thousands of downloads about the new prostate cancer guidelines. Here's a disclaimer. I'll let you read through this yourselves. Just to point out, this is an event supported and organized by Mundipharma. All of us are on the clock a little bit for this. We've been offered honorariums for our services this evening, and many of us have our own individual disclosures. I will acknowledge that the podcast is supported by many of the companies you're all familiar with in GU Oncology, so many of us work alongside these companies. But all of our content tonight is our own independent content created for your education. So this is the puzzle. And what I like to think about is here on the left of the screen, how it used to be so simple in the olden days. Ben, back in the olden days, all we had to worry about was diagnosing a patient with metastases based on a CT and a bone scan, and then starting those patients on ADT. And the only people involved in that conversation were me, the urologist, or the radiation oncologist who might have diagnosed the patient. But then it started getting a little bit more complicated when things like germline screening started along. And then this is the theme tonight. It's when suddenly it's not just ADT on its own. Now we're talking about adding in all these agents, and Ben's going to give us a run through some of these, because we now know that by not just doing ADT, but by adding in things like abiraterone, darolutamide, enzalutamide, apalutamide, and docetaxel chemotherapy, which I've taken off this slide for a reason I'll explain later, all improve survival for patients. So this is what we need to get our heads around. And I think that's one of the key questions that I want to try and learn a bit tonight is, of that I saw 2 of them today, Ben, of those patients newly diagnosed with metastatic prostate cancer, who needs intensification first of all? So it's a little bit about the who, and then we think about the how. And then the how is, well, do you just add in one of these agents? Or what about adding chemotherapy to these agents? Or what about adding radiotherapy to these agents? Or all of these, doublets, triplets, quadruplets, all that sort of thing. So this is how the puzzle is getting more simple. We've moved on from kindergarten level puzzle to slightly more complicated stuff. And I think this has been kind of one of the seminal moments that here in Australia, we need to get our heads around, because in July 2022, just 2 years ago, reimbursement came in for PSMA PET CT. And this is Michael Hoffman's speech where he was celebrating that moment. And that really was a really good moment for patients in Australia. And if you reflect back on everyone who's involved in the pivotal trial, the pro-PSMA trial that led to this reimbursement, they should all be congratulated, including Movember and the PCFA who funded it, and Michael and all the investigators around the country, plus all the patients who contributed. So now we suddenly have, incredible access to this novel imaging for our patients. And the question is, well, who should we scan? And if you look at the requirements here in Australia, this is what the Australian government will allow us to use PSMA for. Newly diagnosed patients who have intermediate to high-risk prostate cancer. So that's a lot of newly diagnosed patients. And that's what these are. We're all kind of familiar with what intermediate risk and what high risk is. So that's what we tend to... Oh, Renu's arrived. Come on in, Renu. Renu Eapen has graced us with her presence. We'll put her back on the screen. How are you, Renu? And here, shove over there beside Ben.
Co-host Ben.
I'm ready.
Yeah, he's ready. So welcome, Renu.
Thank you.
Yeah, he did a good job.
Good
On your way. So this is the moment then when we suddenly have the opportunity to not use standard imaging, but use PET imaging for these patients. And here's a question for you. And I just went and looked at this in preparing for this talk tonight. How many of these patients do you think are out there? Well, the Australian government data suggested that in 2023, there were about 25,600 newly diagnosed prostate cancers in Australia. And then the question is, okay, well, how many of them are localized? How many are intermediate and high risk? And our best source for that is the core annual report that Movember push out. And the report from 2023 actually refers to 2021 patients, but it hasn't changed much in the past 8 years of PCOR reports. And what it tells us is that about 3/4 of all newly diagnosed prostate cancers are intermediate or high risk. About 5% are metastatic and the rest are low grade. So that's like the vast majority of newly diagnosed patients could be eligible for a PSMA PET CT, about 18,700 patients you would expect in 2023. So the next thing I went to do is say, well, how many PSMA PETs under that item number for initial staging did we do in 2023? And the answer is 22,500 scans. So obviously this is telling you that almost every newly diagnosed patient, so 25,000 diagnosed, 22,000 patients had this once in a lifetime initial staging scan. So Ben, we're no longer using CT and bone scan in this country. And this is like the first year of this coming in. So straight away, everyone just kicked over and every single patient practically, bar a few, I'll show you an example, are getting a PSMA PET CT. So that is the reality we're dealing with in Australia. The second way we can use PSMA PET is for recurrence. And of course, this is another way that we diagnose metastatic prostate cancer in the recurrence setting. And in the same year, there were about 11,000 of those scans. So it'll be interesting to see how that changes. This is more about prevalence. These are patients already treated. But, you know, the key message is in Australia, we don't use CT and bone scan. We kind of knew that, but when you see the data, it's quite amazing, really, isn't it? So by the way, I suppose that 22,000 means that a whole bunch of them are quite metastatic. They're not intermediate and high risk. You know. So to find the intermediate and high risk, we do 22,000 scans and we find 18,000 patients approximately. So Ben's going to go through all this, but look, what I want to show you about this is these are the overall survival data and most recently the RPFS data for darolutamide. But this is telling us that, you know, clearly adding in some of these AR pathway inhibitors makes a difference. But the reason I put this up, Ben's going to talk about this, is every single one of these trials, every single one of these patients in all these trials was diagnosed with conventional imaging. So therefore, here in Australia, to add to the puzzle, we have to do a little bit of arithmetic or mental gymnastics to say, oh, you know, what would a conventional imaging scan show? Maybe the question is, do we need to bother that at all? I mean, they're metastatic. So we never go backwards and do a CT and a bone scan. But I'm really interested in hearing what the audience might think. So please ask questions, and especially what the panel think later on about this topic. So that's another question for us to consider then as we look at these cases. What's the impact of PSMA PET CT in this setting? And the final piece of the puzzle, I think, from an intensification point of view is what Amy Hayden will speak about in a few moments. That's the role of radiotherapy to the primary. So remember, these are metastatic patients, and up until 4 years ago, I suppose, or whenever Stampede metastatic arm, radiotherapy arm read out, we never did radiation to the primary. We thought it's only going to deliver toxicity, there's no benefit. But Amy will tell us that there's clearly a group of patients who might benefit. So how do you add that into all the other puzzle pieces will be a question for us to consider. So these are my final things. These are what I think are the key topics in metastatic hormone-sensitive puzzling these days. Number one, how do we interpret the key data, the pivotal data, when we never do conventional imaging? In every other country, it's more straightforward. In the US and the UK, they just are doing CTs and bone scans, so you can quite precisely put your patient into the control group in those studies. Second, how do we choose which option? So Ben will help guide us on that, because we have a whole bunch of options available and nearly all of them reimbursed in Australia. Which benefits patient from radiotherapy to the primary? Yes, as Ben provocatively said at the start, what is the role of the simple urologist in all of this, Renu? So they're my thoughts on where I thought we would kick off by setting the scene for the puzzle. And then I think, Ben, we might hand over to you and see how you can help us with this puzzling business.
I love the jigsaw.
You like the jigsaw?
I love the jigsaw analogy. I think that is really cool. It is true. And jigsaws are sometimes hard. Yeah. But, you know, once you know the pattern, once you figure out the pattern, the jigsaw becomes easier, right? And so I guess we're just learning what is the pattern at the moment because it's new to us. We've just opened the box. We've got all these pieces here. We're not really clear what the picture's supposed to look like. But once we figure that out with time, we'll figure out what the picture's supposed to look like and we'll be able to put the pieces together.
And it's okay to be moving the pieces around, would you say?
Exactly.
Yeah.
We don't need to know everything all at once. We're all learning because the field is moving really quickly and we're just going to move along with it and figure it out as a team. Yeah.
Are you going to use your drop of food colouring in the ocean analogy?
I've worked on a new one.
Oh, right. Okay.
Yeah.
He's the king of analogy.
That's true. This drop of food colouring in the ocean was a bad one. It went down really badly. I didn't even get it by the end, so I'm not going to go there.
Very good. How are you, Renu?
Welcome. I'm good. It's good to be here.
Yes.
For our first ever
live event.
Exactly. It's very exciting.
I was telling the audience at the start, we're used to just pushing out stuff away. And we get comments on social media and YouTube. But tonight, we're going to get questions and comments coming in. So
I was finishing up a meeting and I got a text from Declan to say, we're going live in 2 minutes.
Yeah.
And I went, oh my God.
Well, we don't normally do that. We just start when we start.
Yeah.
So anyway, Ben, we'll hand over to you and I'll bring your slides back up there. And you're on.
Okay. I'm going to focus on who should we intensify. And I'm focused on who we're intensifying, assuming everyone should be getting a doublet. So I'm not going to talk about the doublet options, the APA, the ENZA, the ABI, or the Darrow now, post-Darrow note. I'm just going to talk about who we need to add chemotherapy to the doublet. So I'm going to assume that the audience out there, the clinicians know, I think we've accepted that if you're going to start ADT for metastatic disease, you should be strongly considering, if not starting, an ARPI. Do you think that's fair?
Yeah, but it's also a good first take-home message, I think, isn't it? I mean, because we still need to reinforce that these drugs are only available in the last year, I think, reimbursed. So that's a strong message, isn't it? So everyone out there, when you see a patient in the clinic this week with metastatic disease on a PET scan, newly diagnosed or recurrent, you need to also be asking yourself, why am I not starting an RP, or referring to one of my colleagues who will start an RP.
And I think it's a very rare situation where it's not simple. It's not a simple decision. I think and I've got a situation, maybe we'll talk about this now, before we talk about intensification. I have a patient who's been on phenytoin for epilepsy for the last 30 years. Phenytoin, as I'm sure you're aware, interacts with everything. It's a super dirty drug. I asked my pharmacist, of all these 4 ARPs I want to start, is it going to be a problem? It's going to be a problem with all of them. So now I do want to intensify this patient. He's got metastatic disease, but I've got time, Declan. Yeah. So I'm sending him off to a neurologist. I said, can you sort him out, swap him from his phenytoin to something more modern that's not going to interact? I'll bring him back. I've got 6 months to figure this out. He'll be on ADT. ADT is still a great drug, still very effective to treat his prostate cancer, but I know I'm still working towards adding that in a doublet.
Actually, Renu, that's a good point while you're on it, because if people are also seeing a patient in the clinic this week who they started on ADT 3 months ago and he's back for his first check and his PSA has come right down, you can still start those on an RP now because you've got a 6-month window. The benefit is within 6 months. So if you're seeing a patient back in clinic who you started 3 months ago or 6 months ago, they will benefit.
On that though, it's sometimes difficult to convince a patient. Like they've gone, but my PSA's gone down, doctor.
That's the thing. And I think you will still get the odd urologist who has the elderly patient who goes on ADT, maybe intermittent ADT as a solo treatment, and they still think that's fine. And I mean, I think there is still a role.
There is a role.
Minimal, I agree. I mean, and for the majority of patients, doublet should be your baseline.
You got to think it should be a standard. Yeah. And it should be a conscious decision to step down.
Yeah.
All right. Well, look, why don't we get you to talk us through a few slides? And then we'll go over to Amy. So
I just press forward. Oh, here we go. Okay, who needs intensification? Who needs to go from doublet to triplet? And this is the old days, which wasn't long ago. Remember, I keep drawing this diagram and I've updated now for my patients. I go, well, in the old days, when you had metastatic disease, you started ADT, Declan or Renu would start it. They'd hold on to the patient for a bit maybe, or sometimes they'd send the patients along to see me. And then eventually when castration resistant develops, we would start an ARPI. If it was non-metastatic, in recent times, we've gone into APA, Darrow or ENZA. If it was metastatic, ABI or ENZA. But times have changed. Times have changed so much so that now all patients with metastatic prostate cancer should be prescribed or should be strongly considered for upfront intensification. And that upfront intensification, in my opinion, should be either a doublet with an ARPI or a triplet with an ARPI and docetaxel. Is there a role for a doublet with just ADT and docetaxel? I don't think so, but some of my colleagues still believe there may be a role because it's a short course of chemotherapy. It's not an ongoing treatment and you save your ARPI for later. I would rather give my patient an ARPI and save them the toxicity of docetaxel until later. But, it's a discussion you can have with the patients. From the addition of ARPI to docetaxel improves survival beyond docetaxel, which we'll talk about in a second. What do you think about that, Declan? A doublet with docetaxel alone, is there a role for that?
I don't think so. There clearly was back in 2015 when Charted came out, 2014, 2015, when, wow, adding in chemotherapy really helps these patients. But Nowadays, it's so difficult to justify it. And guess what? Even if you are convinced yourself, it's hard to convince a patient to have docetaxel chemotherapy, even more so than your patient, because their PSA has gone right down.
Yeah.
And the other thing is, I remember, Ben, at the start, people used to say, oh, you know, with docetaxel, you get a hit up front to your quality of life. Yes, you might have some toxicity, you get the 6 cycles, but then you get over that and you know, you're all finished. And by the time you get to 12 months and so on. But Stampede data shows us that there's a significant tail to the toxicity, I think, of docetaxel. It doesn't necessarily all work. That peripheral neuropathy may still be there. So I agree with you. Unless you're in a country or an environment where you cannot access an RP, or you'll have to sell your house to get an RP, and then clearly that would be a conversation. But I mean, the future is kind of now, certainly in Australia, but coming around the region as well, that RPs are available and reimbursed.
You know, I still see a couple of patients where coming back from ASCO, when Charlotte was presented by Chris, that I prescribed docetaxel to, you know, within weeks of the plenary at ASCO, right? And I still see them, and they're still ADT alone, undetectable PSA. This is 10 years on. So there is perhaps some patients, maybe they would have been like that anyway. They were low volume to start with, so maybe they would have been fine on ADT alone. Who knows? But, you know, I personally don't think there's a role for doublet with docetaxel alone, but I'm open to having a discussion.
So the conversation is more about what's the role, as you said out at the start, of adding in chemo to the doublet. Okay, and that's what you're getting to, I think, isn't it?
The second point on this slide, though, here is what about patients who don't have metastatic disease but have non-metastatic prostate cancer? That is advanced, right? Pelvic nodal disease only. I think there's enough data to suggest we should discuss upfront intensification in those patients. I don't think that is as simple as the metastatic patient where it's, now, this is the standard that, and if you want to drop below that, you need to discuss this. The reverse, I think, you start ADT and it's worth discussing it, adding an RP in those patients. What do you think, Renu? This is kind of like
Embark.
Embark, yeah.
Or even the Stampede, you know, Abby added to ADT and radiation, kind of, so
non-metastatic high risk.
Non-metastatic high risk, yeah.
We've got a case, one of our cases has that scenario, so we'll get a chance to hear the rest of the panel talk about it as well, Ben.
Yeah.
Good one.
Cool. All right. Okay, this is the bottom line. You should start with RP plus ADT. And then, so when I try to explain this, I like to draw diagrams. I'm a pretty visual person, you know, I'm red dye in the ocean, you know, so this is the way I've described my patients. And this is absolutely biologically incorrect, so don't take this home, but this is a nice way to think about it. Okay, so ADT, you got to remind your patients, yes, ADT is a very effective treatment, and it does result in the death of the bulk of prostate cancer cells. Right? And I like to say this because sometimes patients go, well, I want to have that RP right now. And I said, well, I've got to sort out your epilepsy first. I'm going to add it later. Don't worry, you're not going to lose out by starting a few months later. You want the ADT now. The surviving resistant cells are the ones that develop into castration-resistant cells. They're the ones that kind of evolve into castration resistance, the one that causes trouble in the years to come. And the way I describe it to patients is by adding upfront RP, you're going to result in deaths on these resistant cells. And therefore, there are less surviving resistant cells, which means there's delayed castration resistance and there's improved survival. Do you like that one? Is that cool?
Love it.
Yeah?
Yeah, that's good. That's very visual.
Yeah. Because, you know, it's important for patients to know that they're getting all that benefit just with ADT alone.
Yep. So now what about the triplet? How do you explain the potential benefit or maybe non-benefit of triplet? Okay, so you can add in upfront docetaxel. When you see these blue diagonal lines here, do they result in the death of additional resistant cells? You see that kind of resistant cell box has gone from 4 cells to 2. Or are they just killing the cells that were killed anyway, so they're not providing a survival advantage? Do you like that one? Is that better than the drop of red dye in a blue ocean? You like that one?
I do like this.
Okay,
Yeah.
good. No, I'll go with it.
That's good, isn't it?
Okay, so let's talk quickly through
And
the data.
that's true. The last 2 scenarios is what we don't know.
We don't know. And that's why it's a conversation about who we need to intensify. If we knew, it's a little flow chart. I follow down a flow chart, we're done, tick the box, done. But it's not. It's a discussion. It's being physicianly, Renu.
I wouldn't know anything about that.
Okay. All right, let's do it. A couple of studies. Just want to remind everyone about the role of triplet therapy. And so the first study was Piece 1. Kareem Fazazi led this. This was a multi-arm study, but the analysis we're focused on is those who received ADT plus docetaxel as 355 patients versus those who received ADT plus docetaxel plus abiraterone. generally young patients, generally high volume metastatic disease, aggressive disease. All right. When you added abiraterone to patients who's received ADT plus docetaxel, there was an improvement in survival, but that improvement in survival seemed to be most in patients with high volume metastatic disease. So this study demonstrated that adding upfront abiraterone to ADT and docetaxel does improve overall survival in patients with de novo metastatic disease, most pronounced in those with high volume. So just a reminder, this is not adding docetaxel to ADT plus ARPI. When the study was designed, the standard of care was ADT plus docetaxel. Mm-hmm. And so therefore the question was, if we add abiraterone to the standard of care, does that improve survival?
So not what you're saying is the current challenge is everyone's in ARPI and ADT. It's the adding docetaxel. There is no data.
Yep, there is no data. There remains no data.
But Ben, you know, some of your colleagues, global colleagues, would sit here and very, very strongly argue for the role of the triplet. They'd be upset about your little, very convincing graphic. So it's very topical. But I think the train has left the station, and I think especially when you speak to patients, they're going to require quite a bit of convincing to say docetaxel is in my best interest now, rather than keeping it up your sleeve.
Yeah, I agree.
And I think that's the issue with extrapolating from studies like PEACE-1 is it doesn't actually answer the question that we're asking.
It doesn't answer the question.
It's not comparing triplet to what is now accepted as standard of care, which is ADT plus ARPI.
That's right.
I can feel the argument building here. I can feel it. Yeah. So
just a quick slide on toxicity. You know, expected toxicities. Chemotherapy is not horrible, but it's hard. You know, I like to describe chemotherapy when I'm talking to my patients. You know, my men who play golf can still play golf. They have a few rough days. You know, but you know, golf is still possible. Those who work can still work. It's not like chemotherapy for breast cancer or leukemia, which is much, much, much harder. Docetaxel and prostate cancer is much more tolerable. Not to be, if you need to have it, don't be too scared of it. But if you don't have to have it, maybe you don't need it. Next study is the ARISEN study, just to bring home the same discussion, a separate study. Again, at this time, ADT plus docetaxel was the standard of care. This question is asking if we added darolutamide to the old-fashioned standard of care, ADT plus docetaxel, does it result in a survival benefit? Mostly de novo metastatic patients, mostly high volume, aggressive disease, over 650 patients in each arm getting a daro versus placebo. And again, here we go. Clear survival advantage when you add daro to ADT plus docetaxel. Again, improves overall survival in these patients with metastatic hormone-sensitive disease, most pronounced in the high-volume metastatic patients. So triplet, when you add an ARPI to ADT plus docetaxel, it is most effective in those with high-volume metastatic disease. But it doesn't, and again, toxicity as expected. So, but we don't know what the benefit of adding docetaxel to ADT plus ARPI is, because when those studies were designed, as we've mentioned, the standard of care was ADT plus docetaxel was changed now, it's ADT plus ARPI. We don't know this. We don't know what the benefit might be, but we know there is toxicity. We've seen it reproduced over and over again. We know what the toxicity is. So we know what intensification, the cons of intensification. We just don't know what the pros are.
if any.
If any. Do we have Chris Sweeney on the line?
Oh, we had him in the studio on Monday night for a podcast. Yeah. But his view about Ben, in fairness to Ben, Chris, he's a very smart thinker. He evolves his view all the time, and you won't find him nailed on arguing for triplet chemotherapy at all here. Quite the contrary.
And same with Ian Davis. He does say now that triplet therapy with docetaxel is the exception.
Yeah. And I think what a lot of Chris's work has been focused on identifying who needs the triplet. Biomarker work, to figure that out. And I think that space is continually evolving, and we may get to the point where we have some molecular test that says, okay, you need the triplet, but we're not there yet.
Yeah, agreed.
So how do we select a patient for a triplet over a doublet? This is where it's all about being a physician, Renu. So benefit seems to be, now if we go triplet and doublet when we're using the doublet as ADT plus dosi, that benefit was limited to high volume metastatic disease. So I think it's fair to extrapolate if adding docetaxel to ADT plus ARPI is going to provide any benefit, it really should be in those higher risk patients, high volume de novo metastatic patients. Would you agree with that?
Maybe or maybe not. Yeah. I mean, they're the only ones. You're
That's
making
what I
the
mean.
point.
They're the only
yeah,
ones.
yeah.
You wouldn't be considering someone with 3 metastatic sites in nodal disease, right? So, and then, so what are the next considerations? Patient situation. How young is the patient? How comorbid are they? How far away do they live from a chemotherapy center? How frail might they be? And then you go to tumor factors. How bad does their biology look? If their biology looks really bad, are you more inclined to intensify? But really, what does bad biology mean? We don't have those biomarkers. We just kind of have a sense that maybe this is bad. So I think the question is, what does the patient have to lose versus what do you think the patient has to gain? And that's where I'm going to leave it.
Very good, Ben.
Yeah.
Did you enjoy that?
I did. I like the analogy.
But I think Amy's talk coming up next is very important, because the triplet I think of for the vast majority of patients is the triplet of ADT, ARPI, and what about radiotherapy?
Yeah.
Because that really is.
Who has their prostate still left in though, Declan?
This is true. Yes, okay. Guilty.
As charged. Yeah.
Look, that was fantastic, Ben.
No, thanks, Declan.
We're building up nicely towards some very good cases, actually. We've got some great cases to discuss on this topic. And we'll get to that after we hear from Amy. But Mike, let's welcome Amy onto the stage if we can. Because what we'd like to talk about next is the role of radiotherapy in metastatic hormone-sensitive prostate cancer. And we're very pleased to welcome Amy Hayden, radiation oncologist from Macquarie University, to the webinar. Amy, welcome. How are you?
I'm very well, thank you, Declan and Renu. Thanks very much for having me on GUcast. It's a pleasure to be here tonight.
It
Good
is,
to see you, Amy.
We haven't had Amy on a proper podcast yet either.
No, we must. Yeah.
Well, this
yeah.
is going
well,
to
this is kind of
We're going to push it out as a podcast.
I didn't realise this was your first live event. It's fantastic.
Yeah.
Yeah, no, it's we'll see. Do we get the hang of it? See what the ratings are like. See, do we pick up any new subscribers?
Yeah, or do we say something stupid that we wish we'd edited? These things can happen. But we're excited for you to tell us about the true triplet therapy.
Yeah, true triplet therapy. So we'll hand over to Amy, who's going to talk about the role of radiotherapy. And then after that, we're going to have some case discussions with the panel. And then after that, we'll have some questions and answers.
Excellent. Well, I'm glad that Ben and I agree, and where I'll be starting from is the assumption that the baseline hormone therapy for a man with de novo hormone-sensitive metastatic prostate cancer is likely to be an ADT and an ARPI. So while the question of intensification of therapy, the question for radiotherapy is, when should we use prostate radiotherapy for a man who is receiving doublet intensification of systemic therapy? And so we've had the data from Stampede and HORAD trials, which was 2018, 2019, and that really changed practice in terms of local radiotherapy to the prostate being demonstrated as having a benefit, primarily for men who were receiving ADT only. Then we had the meta-analysis confirming the benefits, and now we've got some new evidence from the PEACE-1 study looking at the role of radiotherapy in the setting of men receiving ADT plus or minus abiraterone. So that's what I'll be focusing on tonight. So given that that's our new normal for men who are newly diagnosed. But firstly, we'll just take a quick tour through Stampede. Everyone's going to be pretty familiar with this, so we'll zoom through it. So the initial publication was negative overall. So for the overall population, no benefit in terms of overall survival for the total cohort, but when stratified by charted definition, low burden or high burden metastatic disease, there was an improvement in overall survival of 8% at 3 years with the addition of local radiotherapy. This is looking at the more recent publication in 2022, looking at the 5-year results, and this showed that the improvement in overall survival at 5 years had increased to 12%, with a median overall survival increasing to 85 months, the clear separation of the curves with the addition of radiotherapy. So the benefit was sustained with longer term follow-up. This publication also looked at symptomatic local events, or as they called it, local event-free survival. And overall, for the whole cohort, there was no difference with the addition of radiotherapy or not for local event-free survival. But as with many things, the devil's in the details. So this was a composite endpoint which included prostate cancer death as a local event. And as you can see, the numbers of the events are totally dominated by prostate cancer deaths between standard care and standard care plus radiotherapy. So given that there was no improvement in overall survival, there was no improvement in local event-free survival driven by prostate cancer deaths. There's been a more recent presentation at ESMO last year looking at specifically intervention for upper tract obstructive uropathies, so nephrostomies and ureteric stents. And this used hospital-linked data for the STAMPEDE cohort, and that demonstrated that there was a reduction in intervention for obstructive uropathy with the addition of local radiotherapy in the overall cohort, although the absolute event rate was pretty low. The rate was about 5%, which reduced down to 2 or 3% with the addition of radiotherapy. So there was still a local benefit with the addition of radiation. This is just the summary from STAMPEDE in terms of the results. So with a background systemic therapy of ADT alone, with a small proportion of patients having docetaxel, there was an improvement in overall survival of 12% at 5 years, improved progression-free survival in both the low and high volume cohorts, no difference in composite overall local events, including prostate cancer death, but there was a decrease in obstructive uropathy requiring intervention. So these summary results were confirmed in the meta-analysis, which stratified patients by less than 5 metastases or more than 5, showing a benefit in terms of overall survival when looking at both the STAMPEDE and HORAD trials. And then what's low volume? We know that the trials looked at the charted definition, which is that little bit odd definition of high volume being 4 or more METs with at least 1 outside the axial skeleton. So there's been a secondary analysis of STAMPEDE trial looking at the number of metastases, and you can see that the upper, there we go, the upper limit of the confidence interval starts to cross 1 for the hazard ratio for overall survival at 3 bone metastases, and for failure-free survival, you get the upper limit of the confidence intervals crossing 1 at 9 metastases. So using the meta-analysis, you'd use an upper limit of 4. Using this secondary analysis, you'd use an upper limit of 3 metastases, again, as identified on conventional imaging. So this is the analysis using that number of metastases as the stratifier of less than or equal to 3 metastases, again, showing an improvement in overall survival and failure-free survival with the addition of radiotherapy. Now, a common scenario that comes up is patients who've got bone mets and non-regional lymph nodes, and the question is, how do you count those? So in this secondary analysis, it also showed that for any number of non-regional lymph nodes, those patients still benefited from the addition of local radiotherapy if there were 3 or fewer bone metastases. So that's STAMPEDE, but what happens when, as Declan and Ben have already alluded to, that we're going to be using PSMA PET scans to stage patients? How do we count the number of metastases? Who do we determine as low volume or high volume? I certainly don't have the answers. I'm hoping that Louise will have something super helpful to say when we do the cases. Personally, my approach at the moment is still to pretty much use the definition in terms of bone metastases identified on conventional imaging. I usually don't go back and get a whole body bone scan, but you're looking at the underlying CT scan to see if there's a corresponding bone lesion on the PET avidity and trying to do your best count from there. But I'm sure that there's a few different approaches. So that's STAMPEDE results. What have we learnt now from the Piece 1 trial? So this was presented at ASCO last year, and my thanks to Alberto Bossi, who's given me permission to use his slides. And he tells me that the paper is in press and it won't be long until it's in publication. But for now, we're going off the presentation from ASCO. So the PEACE trial was looking at the role of radiotherapy in men who were receiving standard of care plus or minus abiraterone. So the randomisation was a 2-by-2 randomisation, so plus or minus Abi and plus or minus local radiotherapy, and recruited over 1,000 patients. So looking at the comparison of the trials before we go into the results, so there's a couple of interesting things to look at. So background docetaxel use in STAMPEDE was 18%. Versus 60% in the Piece 1 trial. The radiotherapy given in STAMPEDE was either 55 gray and 20 fractions over 4 weeks, or 6 fractions given as a weekly treatment. In Piece 1, it was a bit more of the conventional radiotherapy of the time, given as 2 gray per fraction in 37 fractions. And the other interesting thing is the baseline PSA. So in STAMPEDE, it was 98 for the median PSA. HORAD, it was over 100. In Piece 1, it was 13 or 14 for the overall group. So I don't know how to interpret that, but it is a slightly different group maybe in terms of prognosis between the trials. Okay, so this is the first result. So this is the radiographic progression-free survival, looking at the individual 4 arms. So if we take initially, let's just say that our new standard of care is standard of care plus an ARPI, in this case ABI. There was a significant improvement in progression-free survival with the addition of local radiotherapy, median improving from 4.4 years to 7.5 years, so a substantial improvement with a hazard ratio of 0.65. So pretty big improvement there, but it's still radiographic progression-free survival in the low volume population. Again, looking at the low volume population, looking at overall survival, no significant improvement with the addition of radiotherapy, looking at the overall cohort. And you can see that those 2 curved lines, you can't get anything in between the 2 lines. So no improvement in the overall survival in the low volume cohort, looking at all patients. However, if we look at the 4 arms, again, looking at overall survival, low volume population, still no significant difference in overall survival. But if we look at the standard care plus ABI, which is the red line here, and the standard of care plus ABI plus RT, there does seem to be a separation of the curves. The hazard ratio is 0.77, but it's not significant. But it's pretty important to look at the numbers that we're dealing with here. Because the trials now come down to the low volume population, and we're looking at the base being the standard of care plus abiraterone, the numbers in each group is 120. So it's probably going to be pretty difficult to find that significant in overall survival, looking at the numbers when stratified by the 4 groups. If we have a look at the time to serious genitourinary events, so what's the benefit of radiotherapy in terms of local complications, there was a significant improvement with the addition of radiation, both in the overall cohort and looking at the 4 group analysis. And again, this is in the low volume population. So standard care plus ABI, reduction in serious local GU events with the addition of radiotherapy. So what were these events? You're looking at interventions, but also delayed treatment with either prostate or with prostate radiotherapy or a TURP. So does that weaken the benefit of this arm? I don't know. I think to get delayed treatment, you've had to develop symptoms probably. So it probably is still quite reasonably significant in terms of clinical relevance to patients. All right, now this is looking at time to serious GU events in the overall population, so including the high volume patients as well. An improvement with the addition of radiotherapy, probably a little bit less in magnitude, but definitely still a benefit there. Okay, and the last endpoint I'm presenting is castration resistance-free survival. So this is the low volume cohort, and pretty big difference in the castration resistance-free survival for standard care plus ABI with the addition of radiotherapy. So the median years is 3.6 years versus 6.9 years. So that's almost doubling. Hazard ratio is 0.62. And when you think that the next treatment after developing castration resistance is likely going to be the addition of docetaxel, I think that can also be a fairly meaningful endpoint to consider. But that's a big difference, 3.6 versus 6.9 years with the addition of radiotherapy on top of ABI in the low volume population. Looking at that same endpoint in the overall population, there's a benefit again, but the magnitude is less with a hazard ratio of 0.79 and increasing from 3.1 years to around 4 years, I think. It's a bit small with the typo, sorry. So what's our summary from Piece 1 trial in the low volume cohort? You've got improved radiographic progression-free survival, improved time to castration resistance, decreased local GU events, but the increase in overall survival was not confirmed in the cohort analysed. What's interesting is all of those endpoints also apply to the high volume cohort. So what is the distinction now? If we compare the Stampede trial with Peace trial, so Stampede improved PFS and overall survival, no difference in the composite local events, but there was decreased interventions for obstructive uropathy. And with Peace 1, increased RPFS, increased time to castration resistance, decreased local events, increased overall survival not confirmed. So what does this mean for how we apply treatments for the patients that we're seeing in clinic? I think one of the things to consider, and to be interested in the comments from the studio and Louise, is what's a meaningful endpoint? Do we only offer radiotherapy if there's an improvement in overall survival? Is delaying castration resistance and next-line systemic chemotherapy relevant? Is avoiding a nephrostomy tube a relevant reason to initiate radiotherapy up front? And radiographic progression-free survival, don't know. And of course, quality of life. And that's one of the data points that we don't really have in terms of comparing the two approaches. So what would be nice, but we don't quite have now, is comparative quality of life data. Ben already identified that the Holy Grail is predictive tests to give us further information as to who would benefit. Is response to systemic therapy a biomarker that could be used to determine who would benefit? I don't know. In the end, where we go to at the moment is informed decision-making with the patients about the benefits of treatment and the limitations of treatment and what's meaningful to them in terms of an endpoint. In terms of what I do, I haven't really changed things at the moment with the presentation of the PEACE data, but in terms of going into the details, I might leave that to the cases, Declan and Renu. So that's the end of my talk. So back to you in the studio.
Fantastic.
Terrific. Thank you so much, Amy. Just fantastic. What do you think,
nice,
Renu?
very nice. They're very comprehensive.
Very comprehensive. And I got some key messages out of it. There's a group of patients I think have a survival benefit in the low volume setting from Stampede. And then this topic of reducing the risk of future GU toxicities is something that we'll come up with in the panel discussion. But Amy, thank you very much for that. Wonderful to have it. And Mike, we'll go back to the full studio view now because our plan is to bring a few cases onto the screen. And we have some polls coming with these cases as well. So we'll be asking you for your thoughts on how you would manage different scenarios. And again, we really would love to have your questions coming in. We already have a bunch of questions coming in, but please send your questions in. General questions about the role of intensification or what agents we add or how we stage patients. Anything to do with your metastatic prostate cancer patients, we'd be happy to do that.
Yeah, I mean, you've got a great multidisciplinary panel here, so and a wonderful opportunity to have your questions answered. So please send them in.
So everyone loves a case to perk you up after a few talks, Renu. So let's see what we have to discuss here. We've got 4 cases. We might get through 3 or 4 of them. These are just straightforward cases I've found in the past few weeks. Most of them. One is from a little bit further back. So this is a 63-year-old, kind of long-standing back pain for 10 or 20 years. First PSA was 28, clinically T3. You can see a horrible-looking prostate on his AMR. PIRADS 5, some seminal vesical invasion. He's had a biopsy, grade group 4, and he's had a PSMA PET CT as his primary staging. And so this is his PSMA PET CT. He's obviously got very high volume looking bone metastases, very high SUV max. We'll be interested in Louise's comments about, is it just how much metastases or what about these quantitative parameters? How much do they matter in assessing these patients as well? But we'll go to a polling question, and we wanted to ask a simple question first. And that's, this patient's already had a PET scan. But would anyone in this day and age in Australia go back and do additional scans? So our polling topic is, would you do a CT and a bone scan, conventional imaging? Would you do an MRI of the spine? Would you do both of these? You want to really get a picture with conventional imaging? Or would you do nothing? Would you just make all your recommendations based on the sort of conventional imaging that we see here? So I think the poll should be coming open as we speak to you. What do you think, Renu?
Good question. Yeah, I mean, you've got very good imaging already. That PSMA PET is sort of giving you all the answers, in my opinion.
Renu, whenever I order a PSMA PET, I always order a diagnostic CT, not just a PSMA PET/CT.
Oh,
am I going a bit nuts with that, or like I feel as though I want to see things with contrast that perhaps for the non-PSMA avid disease, I always throw that in there. What do you think about that?
Oof.
Should we ask Louise?
I think we should ask
Louise in a second,
yeah.
because there's a question about that I'd have for you, because that item number for initial staging with PSMA PET, and we've nearly finished our polling, we'll go to the results, specifically doesn't allow you to do a diagnostic CT with it. You're not allowed to claim the item number for a diagnostic CT like with contrast, but Louise can answer that for us. But let's see, what do the audience say? 60% went for option 4, no additional imaging. Sorry, I'll go from the top. CT and bone scan, 7%. So some people, a minority, will go back and do conventional imaging. 21% would do an MRI of the spine. I think they've looked at all those metastases and maybe want to know a bit more.
That's fair.
Some would do both, but 60% would do no additional imaging. Mike, let's bring the panel up so we can have a discussion about this topic of doing additional imaging. You've heard some thoughts there on what this mob in this studio would think about. And we'd like to welcome Louise Emmett, who's on your screens as well. Professor Louise Emmett, nuclear medicine physician from St. Vincent's in Sydney, who's joining us for the panel discussion, and Amy's back on the screen. So maybe we'll go to you first, Louise, to answer this question about doing a diagnostic CT. Can you just answer from a practical point of view? Is that verboten? Is it allowed? No.
Well, actually, to tell the truth, Declan, we embed a diagnostic CT into all of our PSMA PET scans because I have the same fear that Ben has. What are we missing? And if you've got a patient with a scan that looks like the one you've just shown there, you really want to know if they have visceral disease. And you're not going to see that easily if it's negative on the PSMA PET. You want to, what are the negative spaces? So we do embed a diagnostic CT to our PSMA PETs, and I think it's good. I think we should be doing that. We need as much information as possible.
And Louise, is that CT just as good as doing a dedicated CT with contrast? Or is the quality not as good when you separate?
No, it's totally fantastic. So we separate it out. You can report it separately. You can report it together. We look at it together. And so we start with a low dose at the legs. We inject the contrast about the knees, and we do low dose. Then we do high dose over the pelvis, high dose over the liver, and then we go low dose again. I really like it. We've been doing it for years. It gets really good contrast with the nodes. So even if you've got a very small node, say 5 millimeter node, on a CT that actually contrast enhances really, really nicely. So if you've got low PSMA expression, 5 millimeter node, but it's contrast enhancing, it's rounded, and it's in the landing strip of prostate cancer, you can be much more specific and certain about what you're saying about those nodes. So, yep, don't have any problem. I've never asked anyone if we can do it. We just do it.
I think when I
claim for it,
when I order it, it's a different item number, right? For the restaging, is that difference?
Different item number.
Perhaps I need
different item number for restaging, and I think restaging is a completely different kettle of fish. You have a low PSA. In no guidelines does it recommend CT and bone scan for restaging because it's just negative until your PSA is quite high. So I think staging is different. You want to pick up those high volume visceral involvements that may be PSMA negative, and that makes a big difference in those patients.
Because I think we won't labor on it, but when we did Pro PSMA, it was designed to replace CT and bone scan. When we made that argument that you should replace CT and bone scan with PET scanning, and it was more palatable as you're not adding in a PET scan to everything in the trial. And likewise, when I got to the reimbursement bodies, they thought, therefore you can do that scan, the PSMA PET, but you can't claim an item number for a diagnostic CT at the same time.
I think it makes sense that for the Pro PSMA was the diagnostic component.
Yes.
Right?
Yeah. Rather than restaging. But look, so that's great. So most people would not do repeat scans in this particular population. Amy, what do you think? Don't do any extra scans? Do you want to know about the back?
I don't think we need to do extra scans. In terms of the question about the MRI spine, it's got a bit of back pain. It's not unreasonable to do an MRI spine, but my preferred approach is actually that you review the CT scan of the spine first and see if there's any big, chunky bone metastases where there's some, posterior broach of the vertebral body that you're worried about. If you don't think you see anything on the CT scan that's worrying, I don't think you need to do the MRI. And usually these patients will have a symptomatic response with the commencement of their initial hormone therapy anyway. If it was persistent beyond that, you could have a look, but I don't think that most patients need the MRI spine, but have a good look at the CT scan.
Okay, so this patient didn't have any additional imaging. Mike, let's bring the GUCast studio back on the screen, and Chetna, you can open the polling for the next question as well.
Declan, can I just argue for the 7% who chose to do a CT and a bone scan?
Yeah.
I think if this patient has such widespread metastatic disease, do you want to keep assessing them with PET in the future? And some clinicians, oncologists might say, I want to do a baseline CT bone scan because I want to have a baseline to compare response. I don't necessarily think that's necessary. Your first restaging scan, you can perhaps do an apples to oranges comparison, then keep going the CT and bone scan for that. But that might be what the 7% were thinking.
Yeah. If we had a split of what sort of people are voting for that, it might be the medical oncologist.
For sure. Yeah.
Okay. Very good. Okay, so let's have a look at the next option here, because what we want to do is asked the question of what are we going to do with this patient. So you have options on the screen, and the polling is going to be opening in a second. Number 1, ADT alone. Well, that's what we spent the first few minutes saying we probably shouldn't for most patients. Number 2, ADT plus an RP doublet. Number 3, ADT plus docetaxel. That's what we certainly would have been doing a few years ago before RPs, but Ben brought it up earlier. Is there a role for an ADT docetaxel doublet in Australia in 2024? And finally, the classic systemic triplet of ADT, dosi, and RP. And Amy, we will ask your opinion on adding radiation, but this question is really about the systemic intensification. So that's what we want people to hear about. So vote away. What's your prediction, Ben?
Should we play some bets on the percentage of triplet? Do we know how many oncologists are on the line?
That's cheating.
Yeah. I'm going to go, I think this might be 50-50, RP versus triplet. What do you reckon, Renu?
I also think there's going to be a not insignificant number of people going for triplet, just because of the volume of mets, right? That's going to scare people. But remember, it's all bony mets.
Yep.
The votes are coming in. What
He's 63. He's young. He seems fit.
I'm for 2. I'm for doublet with RP.
Yep. Okay, well, so what are the votes telling us? Hey!
Oh my God!
So
spot on.
It's spot on.
How many people did you bribe to vote for triplet?
I've been texting furiously then.
Half the population.
Wow, that's amazing.
Half the participants are going to say ADT plus RP. Half of them are doing triplet practically.
Wow.
And 1 or 2 people are doing ADT alone. That's interesting.
It's a discussion. It's a discussion. I would definitely discuss a triplet with this patient.
Yeah.
Assuming he's 63 and fit.
Just volume of meds?
Just volume.
Mike, let's bring back up the panel while we're arguing here.
Wow.
Yeah, so it's quite high, the triplet, isn't it? Because, you know, I love going back to the tweet I keep sending out about this, but there's no evidence that adding chemotherapy to a doublet improves survival, and it definitely decreases quality of life. That old-fashioned thing I keep saying. But half you people out there are telling us, nope, we'd add.
And Louise, what do you think?
Yeah,
I actually think it's really interesting because we have a PET scan that shows high volume disease, but what does a conventional imaging, where's the bone scan? Does it have a high volume disease? You get a lot of patients who get marrow involvement with bone who don't actually have abnormality on the bone scan. It's a stretch, but maybe they don't have high volume on conventional imaging.
Yeah, good point.
And do we just move over? Is that what we do? We just move over with no bridge, no understanding of really what high volume is on PSMA PET, what low volume is.
For sure. Let's draw a line in the sand.
Evidence-free zone, right?
Yeah, it's.
I'm truly surprised. I mean, I was thinking maybe
just
it's bone only. Yeah,
it wasn't really the bad actors like Ben was talking about.
It's not the horrible liver and.
It seems bad.
Yeah.
Okay, it looks terrible.
I'll talk to him, right? You'd say to him, okay, how much is it? Some patients go, Ben, I want to do everything I can to ensure I live as long as I can. And other patients go, Ben, I just want to make sure my quality of life is all right. And so, those are kind of easy decisions. Quality of life, no docetaxel. I want to do everything. Well, there's no evidence to prove it. But
then you might as well give him lutetium PSMA. I mean, it's an evidence-free zone, right?
You've got some evidence now, haven't you?
Kieran, can you find out for us how many medical oncologists are on the line here? To text Amber and say, I'm really interested, because the urologists are not voting for the triplet docetaxel. No. And here's the little thing for you, Ben, just poking, isn't the reality that for a patient like this, we're starting him on an RP doublet, the urologist or the radiation oncologist who has diagnosed this patient. And I mean, we're not even sending them a lot of the time, to be honest. We put them in the MDT, but,
Right.
Yeah.
This is why.
So I'm afraid that half of people who are voting, I'm afraid, if you're not urologist, you mightn't even see these patients. And
But I don't think,
maybe that's wrong. I'm screaming at the TV now.
Yes.
I don't think an oncologist would be pushing very hard for this patient to have a triplet, but I think it's a discussion.
We're hearing half the audience are medical oncologists.
Oh, there you go. That's the half that voted for triplet, I reckon.
So that helps us understand the future voting as well. So Amy, just on this case, and this is a high volume bone metastatic prostate cancer. What would you advise about radiotherapy in this setting?
I wouldn't offer radiotherapy. Or triplet. Yeah. So no, I wouldn't offer local radiotherapy. From the data that we've got so far from Stampede, it's the low volume cohort that I'd be offering local radiotherapy to. The question that's sort of come up with the PEACE data is the reduction in GU local events a reason to give radiotherapy for a higher volume cohort? Paper's not been published yet. Overall, the absolute rates of local morbidity are still fairly low. So if a patient didn't have significant symptoms up front, I wouldn't be offering local radiotherapy.
Okay. Can I ask something of Amy?
Yeah.
Okay, Amy, so let's say this patient had a triplet because they saw a urologist that recommended them, say, a medical oncologist to consider chemotherapy. Rare situation, but let's say that happened. And the patient had a complete metabolic response except for uptake left in the prostate. This is like 18 months post-diagnosis. And there's no PSMA uptake. PSA is 0.02, and there's some faint uptake left in the prostate. And then the medical oncologist asked you to see the patient. Would you consider radiation to the primary now? Or what would you say?
Before I answer the question, Ben, have you ever seen this scenario? Or are you just making this up as the,
yes, I have.
the 1 in 1,000?
I've seen it too. I've seen it too.
Maybe 4 patients.
But this is faint uptake on PSMA PET.
Faint uptake in PSMA PET. This is like out there. This is outside the box.
I don't think I would offer radiotherapy. I can understand, you know, the rationale for it. I would probably wait and treat on local progression. And if they were only
I had one patient who was like that, Amy.
Then, you know, I think you could consider it as local treatment for castration-resistant oligoprogressive disease, but I probably wouldn't offer it for oligo-residual in the local prostate.
I think there's no right or there's probably a wrong, but that's not wrong. I had a patient just like that, Amy, who said, no, actually, I'm all right. I don't need radiation. And then his PSA became undetectable when the next PET I did, because I just was interested, there was no longer any uptake in the prostate. And he had this amazing response to a triplet.
Okay.
But even a little bit of uptake in the prostate doesn't necessarily mean disease.
It could be normal prostate.
It could be normal prostate, right?
Yeah, exactly.
Yeah.
If you had 2 of them, that would be anecdata then. Yes, that's right.
Before you move
Let's
on,
do another case.
Oh.
Sorry,
yes.
Louise.
I was just going to say, you know, you guys, upfront PSMA, you know, it's been published in Lancet Oncology really recently. What do you think about a different kind of triplet? I think we should ask that before you move on.
Oh, yeah. There's no voting there to say adding lutetium. You get asked it all the time, don't you, Ben? So a very nice study, again, multi-center study from around Australia. Great to see it published, great to see it on a big stage. And but it's not practice changing, I think everyone would say. We did a podcast here with Michael and a run about it. And but certainly food for thought that adding in lutetium to a doublet
with docetaxel.
Yeah, with a docetaxel doublet. Yeah, exactly. Added something to it. It's from the olden days. But look, let's bring the studio back up, Mike, and we'll do another case. We've got time for maybe 2 more cases, and then we've got about 15 minutes for questions, and loads of questions have come in, so thank you very much for that. Our next case is going to be a BCR setting. We're kind of at the other extreme of this one now. So this is a patient who is, I just saw this week, he is a commercial pilot, so he has had a commercial pilot's license. He's kind of stopping the big flights, but he's doing a lot of training. He had a radical prostatectomy 4 years ago for nasty cancer, had salvage radiotherapy when his PSA was 1.3. PSA went down to 0.16, but now it's rising. As of June this year, it was 0.3. It had gone 0.16, 0.21, 0.3 with a doubling time of about 12 months. So we would describe this as low-risk BCR by the EMBARC sort of criteria. And had a PSMA PET CT done by someone else and came to see me for opinion. This is his PET scan. It shows a 4 millimeter avid lung nodule, you can see on the top screen, and a 4 millimeter avid lesion T12 described as a metastasis. So the conundrum for him is CASA are telling him you've got metastatic prostate cancer and you can't fly. You can't even do training flights. There's a class D license, I can't remember, because of this. And he's very concerned about it. And I'll tell you his management in a minute, but you can start the polls, Chetna, while we read through this. So his options are, as you see on the screen, we have do nothing, just watch it. Come on, his PSA is 0.3.
PSA doubling time is 12 months.
His PSA doubling time is 12 months. So, I mean, very many of us would not have done a PET scan at 0.3 for someone who's had radiotherapy and surgery already. So do nothing. ADT on its own, ADT monotherapy, ADT plus an ARPI. We talked a bit about this scenario earlier of BCR. So that's why. Or finally, what about an ARPI on its own? And so the reason we've put that up as an option and these up as options is the EMBARC data, which we haven't dived into tonight, but EMBARC is something that we're going to have to embrace in our practice in the coming a year or two as it becomes available. So EMBARK was for this so-called high-risk BCR people who've had surgery plus or minus radiotherapy. They've had their pelvic treatment, and now they've got BCR. The PSA had to be above 1 and the doubling time less than 9 months. So he's not even in the high risk. But those patients were randomized to options you see here, ADT on its own or ADT plus enzalutamide or enzalutamide on its own. So that's why I've put an RP up on its own as an option. So let's see what the polls are telling us. Ben, what do you think?
I think it's going to be evenly spread.
Between all of them.
All of them.
Yeah.
Here we go.
No.
Votes are coming in.
Too many medical oncologists. What do you reckon, Renu?
Yeah, look at that. 30% will observe.
I think it's too many medical oncologists on the line.
You reckon?
Yeah.
47%.
No,
So half of people will do ADT
enthusiasm
and
for an
RP.
RP alone.
What do you think is influencing people, Ben? Is it the lung met?
Yeah, it's a lung met.
Yeah.
But I think observation is I think any option is fine. But
ADT alone even?
Except that.
Yeah.
Yeah, except that. Yeah, you could justify it to yourself why.
Yeah.
You know that it's BCR, so I can't give an RP.
I'll tell you what he did. He's been on ADT and darolutamide, and his PSA is now undetectable. Of course.
Did you observe him for a period?
He came to me after he'd started it, and he hadn't had his first PSA, so I checked his PSA, and I'm trying to convince Kaza that And it's interesting. Kaza wrote this long, detailed thing quoting the Arsens trial.
Wow.
Because of this, and these are the events, and he might have this, and this is our threshold. And
Wow.
but I said, so I've just written this report back saying, hold on, these Arsens patients are completely different to this patient.
You're right.
PSA is 30 to 40, nearly all de novo metastatic.
And no one had a PET
But it's
scan.
because he's had darolutamide, they went and reached for Arsens. And now I've written back and said, this is more like the EMBARK population, and this is the event rates in the EMBARK population.
Yeah.
But Mike, let's bring the panel back up while we hash this one out. So this is BCR, PET imaging only. Clearly, he would be M0 by conventional imaging, and his PSA is only 0.3. I personally would have observed him, but I think, his physician was, he was really pushing to be told he can fly again. So, okay, treat him, especially Doublet. His PSA will clearly disappear, but it hasn't worked so far. It will work. I'm sure we'll be able to convince them. But Amy, any thoughts on this scenario?
Well, I guess my first question was, he had ADT with his salvage radiotherapy. Has his testosterone recovered, or has he got a rise in PSA with castrate testosterone level? Because that really changes the scenario.
Great question. I asked that question. And his testosterone had reached 8 when he was started on his ADT in June, and his PSA had reached 8. So it was still coming up, but it was below 10, but not castrate for sure.
And this is another question, this time to Louise, before giving an opinion. Louise, do you think that lung met is real? Could it be not prostate cancer?
So that's my first thought. The SUV max on the lung met was about 3.4 and the SUV max on the bone was about 4.3. So they're both very non-specific intensities. It's not very, very bright. Lung met, we diagnose other cancers not infrequently at those kind of intensity scores. So I think I was actually up for an observe and possibly a repeat, or start an ADT and repeat and make sure that it's gone, to make sure you're not actually looking at another cancer, because that does happen, and it can be a problem, and you don't want to miss it.
Yeah, true.
One of the things that might get discussed in an MDT is there a role for stereotactic radiotherapy to small volume sites of metastatic disease? Any comments from the studio?
So I think in the APCCC, Amy, people now are very much of the view that if you have oligometastatic disease, you should be treating it with doublet systemic therapy, but there's a role for adding in metastasis-directed therapy, but there's no data to support it. But when you ask people to vote on it in the APCCC, it gets not always consensus, but it gets like 60-75% of people will say, yeah, give a bit of SABR to the bone met, as well as, so what few people will do is only do SABR to the 3 bone mets. Nearly everyone wants to have the systemic treatment on board, I think, and that's probably clinical practice in Australia. I think we use a lot of SABR when you can still see that lesion. Well, we'll do a doublet, but let's that solitary thing, make it go less colorful on the PET scan. The patient likes it when they don't like seeing the colorful spots. I don't know. We use a lot of metastasis-directed therapy without great evidence.
It's a good summary. There isn't the evidence, but a lot of it gets done, isn't it? So,
yeah. That's good fun. But can I ask some questions?
Yes.
So we've got about another 20 minutes to go. We had another couple of cases, but there's so many good questions coming. I think we'll cut to questions. So this is from Anonymous. This is a question about this is interesting. The increased cardiovascular risk in Doublet with RP. So there was a paper published about this in PCAN a couple of months ago. I saw it from Canada, I think. There appears to be reports of statin use and risk if men are also on an RP. How can doctors manage men with high cardiovascular risk and hyperlipidemia if diet and exercise doesn't get the lipids to target and they need to stay on a statin? So you've got a patient with cardiovascular risk factors, Ben. They're on a statin as well. So this brings in drug-drug interactions. How do you approach those patients in, I suppose, maybe managing their risk, but then choosing an RP? This is the physician thing now. You promised to teach us how to be physicians.
So I think here, the one member of the team we don't have here tonight is a GP. I think a GP is a really important part of the patient's team, right? So, and we do know that different statins interact with different ARPs in different ways, and different ARPs have different kind of impact upon cardiovascular risk. So if we just talk about lipids solely, the patients on atorvastatin, for instance, enzalutamide can make atorvastatin less effective. So it's fine to start enzalutamide in a patient taking atorvastatin, but you should monitor their cholesterol, and you might need to get the GP to titrate up the atorvastatin if the lipids kind of get out of whack. On the flip side, rosuvastatin or Crestor, darolutamide can increase the levels of rosuvastatin. And so if the patient's on Crestor, they've needed to be on Crestor because there's less myalgia or whatever, or because that's the better lipid for them. You can still start darolutamide, but you'd monitor them for myalgias, and you'd monitor them for kind of statin-related toxicity, and you might need to reduce their darolutamide and monitor their lipids. So I think a GP can be really good at helping at that. I think you guys have. When's the last time you ordered a lipid profile? Yeah, so that's why it's really important to get a physician on board or a GP involved in understanding these nuances.
Yeah, that's a great point.
Yeah.
Nurse-led, protocol-driven clinics can be good for this as well.
Yeah, definitely. Yeah. Excellent. Yeah.
Okay, good question. Here's a specific question about, is there a role for chemotherapy? So there's an example coming up here. A 69-year-old, he's got T4N1, so locally advanced Gleason 9 cancer involving the bladder. He's got sub-centimeter avid pelvic node. So it sounds like pelvic-only disease, but horrible pelvic disease. Gleason 9. Is there a role for chemotherapy for that patient? I suppose we're talking about the patient's going to be on ADT and an RP, but those patients don't normally get much intensification.
They need Amy, don't they?
Yeah, I need a question for Amy.
So, yeah.
So I think the answer from the audience is that Stephen in the audience is that no, Ben probably wouldn't offer chemo. I suppose the question's about local control in the pelvis, Amy.
Yeah, so I'd recommend that you have radiotherapy to the prostate, pelvic lymph nodes, together with ADT, and ideally an RP, as per the Stampede M0 results.
So you would include the pelvic nodes?
Yes. If the disease is only in the pelvis, I would include the pelvic lymph nodes, definitely.
It's
if
T4 into the rectum.
Then usually it would be radiotherapy to the prostate only.
Yeah. How do you manage those patients when the rectum is, involved, almost obstructed? How do you contour those, or what do you say to patients?
I think if they're almost obstructed, those patients are going to benefit from a period of cytoreduction on hormone therapy before giving radiotherapy, and making sure that they're functionally okay, that they don't need a defunctioning colostomy. If they do, obviously it's really terrible disease. But usually after a period of time on ADT, we can treat them, with radiotherapy relatively similar to the way that we normally would. Obviously, you're needing to make sure that you're treating that anterior rectal wall to include potential disease.
Declan, have you ever seen a situation like this where you might do an exenteration?
Just thinking, we had a patient in the MDT last week, didn't we, who had, he presented with a locally advanced rectal cancer. So kind of the other way around, Amy, rectal cancer pushing towards the prostate, but had a prostate cancer 4+3 diagnosed same time. So the radiotherapy included the rectum and the prostate about 2 years ago, but now he's got a fistula, a really troublesome fistula between the prostate and the rectum. And he's got widespread metastatic prostate cancer. Unfortunately, he's got a PSA of 86 and bone mets. So it's a terrible situation. So that was kind of fresh in my mind, thinking, that's obviously a risk anyway. But I think you outlined how you might reduce that risk. Question to follow on it, Ben, is so this patient can't have an RP then? He's not metastatic.
No, I know. I was trying to ignore that point.
Yeah. So Amy, I suppose everyone's going to ask that question. What about adding an RP into this sort of terrible cancer? And I suppose that's where ENZA-RAD and DAZZLE-HiCap, these trials that have fully recruited, are testing the idea of adding in an RP to the ADT that you use for these pelvic radiotherapies. What are your thoughts on it?
Well, I suppose the data that we have at the moment is for ABBY and PRED from Stampede, but not PBS funded in Australia, so that makes things difficult at the moment. ENZA-RAD's due to read out, I think, next year sometime, so that'll give us an answer about whether or not enzalutamide is going to be a benefit. I think with the ENZA-RAD cohort, it'll be interesting to see if that's positive in terms of the cohort that was recruited. Was it a high enough risk cohort that they're going to need the benefit of additional doublet systemic therapy? So I don't know what the results will be with ENZA-RAD, but in an ideal world for this patient, you'd have abiraterone as per Stampede. What people do in clinics, I think, probably varies, Ben.
Yeah, I've offered some patients self-funded abiraterone and kind of
a Stampede.
Yeah. And I have maybe less than a handful of patients have done that.
How much is it now? There's kind of a generic one in it.
It's still about 3,000, kind of standard dose a month. But if there is some data to suggest low dose abiraterone with food achieves similar PK to full dose on an empty stomach, so that quarters the cost.
Amy, is there a time frame in which you would offer prostate radiotherapy? Is there any cutoff point where you wouldn't give it? So this is the metastatic hormone sensitive population. They've started a doublet, let's say, and then we refer them to you for a chat. When do you offer radiotherapy, or when do you not, I think is the question.
I don't know what the timeframes were in Stampede and Piece 1, but look, ideally, I think you want to get started within the first 3 to 6 months after patients have commenced their appropriate medication, if they've needed any local intervention. But I don't have an absolute cutoff, which I think it's right or wrong to give radiotherapy, but I'd say ideally within the first 3 to 6 months, preferably within the first 3 months, and it should just be commenced pretty much as soon as you can, unless there's a reason why the patient doesn't want to. Sometimes they've got a holiday planned.
Often it's kind of a question of sequencing as well, isn't it? Well, let's get going on the ADT. We're adding in the RP. Your PSAs come right down, and get all that going, and then 3 months in, first PSA, go on and have a chat with Amy.
Yep.
Louise, you mentioned you were flagging upfront PSMA earlier. David is asking, giving these positive results, so we briefly summarized it, that's adding in lutetium to a doublet for metastatic hormone sensitive. Given these positive results, will the new triplet therapy be ADT plus RP plus lutetium replacing docetaxel? So it's kind of a good question. It's not exactly what upfront PSMA did, but it's doublet plus lutetium. Would that be a more palatable doublet? I mean, we don't have the data for it, but I suppose a little bit of crystal ball gazing is what David's asking you to do.
Yeah, so PSMA addition is looking at that, isn't it? It's looking at RP plus ADT plus 6 doses of lutetium PSMA versus ADT and RP alone. So it doesn't have the docetaxel in there. But, I think one of the problems we know that we get downregulation of the PSMA receptor, and what does that actually do when you have lutetium there, and what impact is that going to have on PSM addition? So it's super interesting what PSM addition looks like. I actually do think that adding the yin-yang of the androgen receptor and the PSMA receptor in metastatic hormone-sensitive prostate cancer could be really nice. But I think you have to be very careful how we do it. And I think the results from upfront PSMA were also really interesting. They were stronger, I guess, than most of us expected. How does that impact with an RP?
Can I ask Louise a question? So Louise, early on, if PSMA expression is lost, let's say you've been able to schedule the lutetium early enough when the PSMA expression remains high, and now they're receiving the 5th cycle of lutetium, but there's no more PSMA uptake. What's the benefit there? Is there any benefit for that cycle?
It is very expensive urine. Probably. I'm not sure that we can say there's any benefit at all. I think PSM addition is going to be super interesting. That's exactly what they did, is they gave all 6 doses without imaging right up front, and that will test that. Is there any benefit in 6 doses, and in whom is it going to be a benefit? There's 1,150 patients on that study, so they'll get something out of it. The question is, will they get a positive trial? I don't know. Does it mean it's dead and that we shouldn't be using lutetium PSMA then with an ARPI? I think no. I think it's a super good question, and we need to be doing intelligent trials in the space.
Are you going to be looking for secondary cancers in the sewer rats?
Well, I mean, it's interesting, the concept of lutetium PSMA, because it's so different how it works. It's such targeted therapy. And Michael always says, I mean, it's not a magic wand. You need to have those PSMA expressing sites for it to work. So the type of dosing that you did, for instance, Louise, in the ENZA-P trial is, you know, you're tailoring the doses to their scan results. I think that's sort of got to be the approach we take when we use it further and further upfront.
Adaptive dosing. So, you know, treating when you have the target, not treating when you don't have the target. And I think one of the things about metastatic hormone sensitive space with adaptive dosing that's super nice is you actually, so you give a couple of doses, if you lose the target, you stop. But when you restart again, those are androgen resistant clones because they're growing in the presence of ARPI. They're the ones you really want to knock off. So absolutely, I think we should be doing that. I think it would be lovely to see a trial in that space.
Well, we have you on the line. ENZA-P, you're due to read out the final data or the OS data. Can you give us not the results, but when are we going to see the ENZA-P data? Because everyone's talking about this coming soon.
Yeah, so the ENZA-P data is, so we've analysed, it's closed. The study is closed. We have analysed final results, and there will be an abstract being put into ASCO GU in the next couple of weeks. And so I'm hoping that ASCO GU like that abstract, and we get to present the results there.
Great.
Nice.
Might get a poster at ASCO GU. Yeah.
Maybe, if we're lucky.
Very exciting. Okay, that was just a dip into CRPC. How are we going? We got another 8 or 9 minutes. We got a few more questions. Amy, how do you decide between a weekly regimen versus 20 fraction schedule, as Stampede allowed both?
Look, I think you can use either because they were both used in the Stampede trial. Outcomes were equivalent, so it really depends on patient preference and centre sort of preference. I did a quick poll of some GU radiation oncologists, 10 people 2 days ago, and it was most people were using 55 and 20 for the majority of patients and using the 6 fraction schedule for patients who had to travel or just preferred a fewer number of treatments for convenience factor. I think a lot of us have been a little bit hesitant to use the 6 fraction schedule for patients who've got big bulky disease because we're very comfortable and know the 20 fraction schedule, but in reality you've got the choice of choosing between the two.
Very good. Nice. So I think you adapt to your patient and his preference and family preference is the answer. Mark is asking, Ben, so if you start doublet therapy for node-positive prostate, so I don't think you could even do that as we were talking about earlier.
This would be the abiraterone axis, right? This would be the...
Yeah, exactly. Yeah. But if you did start it, let's say, or how long do you continue following treatment of the primary and nodal disease? So I suppose this is a bit about intermittent. So we haven't talked about that, but a whole really important topic in intensification in mHSPC is, well, you know, it's great to load everything in up front, but especially for like retroperitoneal BCR, we would traditionally be managing them with intermittent ADT. You can keep them going for years and years and years on and off. How do you de-intensify after you intensify?
I think I'm happy to answer that question. But I think Mark's referring to those getting radiations to the prostate and the pelvis with ADT, and then we've thrown in a bit of ABI. And if that's the case, then probably 2 years, Amy, like you'd go 2 years.
It was 2 years in the Stampede trial, so 2 years. Yeah. And then
but your question about de-intensification is, well, if you've had a great response, PSA's undetectable, close to it, and you've struggled with ADT, then I'm happy to kind of discuss the intensification intermittent approach after a year. It's a discussion, again, no data.
Yep.
But like, what are the pros and cons? What are you going to gain by taking some time off? How long is it going to take before your testosterone recovers? Are you going to be comfortable watching your PSA slowly climb? Because if you're not, then you're not going to gain that lengthy period off castration, right? So that's a discussion.
I'm really happy to hear you say that. But, you know, Renu, when we were in Lugano at APCCC, this question came up and people were saying, we need to wait for the data. There are trials going. What's the one Arun's involved with? De-escalation?
Libertas.
Yeah, so there are de-intensification trials going that will take 50 odd years to read out in this setting. But my view is that we can just extrapolate from the intermittent ADT data. Come on, this is just intensified ADT. we can't really just afford to have these patients on doublets for 15 years.
I agree. I mean, I think when it comes to survivorship and quality of life, and we're talking about an option that gives them less toxicity, gives them better quality of life, I'm not sure that we need that kind of data
trials,
to have that
just
discussion.
give them a break.
And if the data comes out later and shows we're wrong, then we'll accept it, right?
That's right. I mean, there's always that risk anyway.
And this is part of being a physician. Anyone can follow a flowchart, even a urologist. But it takes a physician to kind of nuance the facts with fiction.
Yeah, he's throwing the punches in there, Renu.
I'm looking forward to the next question.
We're almost
have you seen
done
that
with
question
the
coming?
trial.
You're watching the question list. Oh, yeah. Well, yeah, no, I do think that the intensification thing is very, very important. And I do think that we shouldn't be waiting for trials. I think we should be having the conversation. And it's just an extrapolation from the intermittent ADT. That's my view. And I'd be prepared to accept that as a patient to say, yeah, we're not quite sure, but we will restart you. And by the way, and I've done that already in the doublet era, since we've just had kind of the first year and a half of people we started on doublets last year. Their PSA is completely wiped out, and we can give them a treatment break. And I think within PBS, my take, we've had these discussions is if you're stopping the ADT as well, and then things come back up, you will fulfill PBS criteria to say, are they starting this within 6 months? And it's the same drug, they haven't progressed, et cetera, et cetera. The questions we have to go through. So it's definitely, that's not the reason not to do it. Is what I'm thinking.
And we also, I mean, we already do it in practice when we dose reduce and when we deal with drug interactions. We're already doing it for patients' quality of life.
Yep.
So
5 minutes to go. This has kind of been dealt with. Is theranostics and ADT an early option? That's up from PSMA and PSMA addition, as we were talking about with Louise earlier on. So that is an emerging thing, and well done again to the Australian investigators who led that first randomized trial recently published. Here's the question Ben's been licking his lips looking at. Are urologists ready to manage the side effects of ARPs, though? Who asked this? It was clearly another medical oncologist.
No, because the next point means it's coming from a urologist. Okay,
are urologists ready to manage the side effects of ARPs? And if so, do we even need to refer to medoncs anymore? Oh, there we go. We'll ask your opinion, and then we'll ask the rest of the panel.
I think it's great that we involve more people and more craft groups in managing these patients, right? And I think it's just learning from each other. Like, you guys have a different perspective to medical oncology. You've seen the answers to the polls we've done, right? Clearly, medical oncologists are more aggressive and urologists are less aggressive. And so I think as long as we're all open to learning from each other, that's no problem.
You're such a diplomat. Send him into a war-torn wherever. He can solve all the problems. Yeah, I mean, and as you know, that's been my practice. I start patients myself and I send them to you when they've got side effects or some abnormal blood test.
I'm a medical oncologist specializing in side effect management.
Look. And I don't know, Renu, we've done so many podcasts on ARPs over the past year or two, but our main message is normally, for us urologists, the really important thing is to make sure that we identify the patients, and whether we as the urologist feel comfortable and skilled enough to make those recommendations to patients, or we send the patients on to our GU medical oncology colleague. It doesn't matter as long as the patient gets the option. So that's still the theme of it, I think. But we should also feel very well equipped that there's a great resource there. We've all picked this up. It's
our role as medical oncologists is to make it sound extremely complicated. So you guys just send them along.
Right. Well, I mean, I think it's easier and easier for urologists to do this in a multidisciplinary setting. Like you say, we do learn a lot from each other, and I think that's a very personal question. I think you don't dabble in it, like Fred Sard always says. Either be committed or send it on, but just make sure patients don't miss out on this important treatment.
And I think that'll happen in urology practices. People who've come through good fellowship training programs will be in a practice where there might be a lot of prostate cancer, but he or she might say, I'm really interested in this advanced prostate cancer. And they might choose to take this on in their practice, be the go-to urologist, and like we kind of are to an extent. So urologists can take that on, and there'll be less surgery in the future, maybe less radiation as well. And when Louise and co put us all out of business. So take an interest in the RPs.
I thought you were retraining, Declan.
Me, yes, a nuclear urologist. Yes. Two last quick ones. Amy, a question from Anonymous about the role of stereotactic for low volume METs, I suppose. Yeah. So what's your typical recommendation for stereotactic radiation in low volume METs?
So the short answer, given that we've only got a few minutes left, would be that obviously there's some evidence in the recurrent setting, currently no evidence in the de novo setting. That'll be the next arm of the Stampede 2 trial, which will be randomising patients to local radiotherapy, ADT, or optimised systemic therapy, plus or minus MDT to the sites of metastatic disease. So the by-the-book answer is we've got to wait for the evidence. In reality, and as you've alluded to, Declan, APCCC for someone who's presenting with de novo oligomets, usually the majority vote is for some metastasis-directed therapy to low-volume oligometastatic disease, together with ADT and an ARPI and radiotherapy to the prostate. But you know, we will need more evidence to see if there's a survival advantage or is it other endpoints that are being affected. I do offer that for patients with 1, 2, maybe 3 bone mets, but beyond that, I don't think that there's a role.
Thank you. And the follow-up question
is coming back to the point about quality of life and side effects. One of the benefits of stereo for low volume mets is probably not, well, we don't know if there's a survival advantage, but I think it gives you more options for temporary cessation of ADT on an intermittent protocol if you've ablated all of the disease to extend that eugonatal progression-free survival, a la the Extend trial from Chad Tang. So I think that there are some quality of life benefits in terms of having the option of going to intermittent hormone therapy by treating all upfront disease.
Actually, as I read that, the follow-on question, I think I misinterpreted the first question. I think it might have been about stereotactic radiation to the primary.
No, I think it was low volume mets, but it's gone
as
now.
opposed to prevention.
It hasn't. Yeah. So but just looking at that last question was, would your choice change for local radiotherapy if they had locally advanced T4 disease at presentation or bulky T3B? This is the area I'm a little bit still on the fence. So you've got the data that I presented showing decreased in symptomatic local GU events. How should we select patients for radiotherapy? I don't think everyone should have radiation, but if they've got very bulky or symptomatic disease or required some intervention up front, I think it's a consideration and it's a discussion with the patient at the time. So I think it's an option, but I'm still not clear on who we should be offering that to.
And that's it. That's all the questions.
That was good. Good question.
Yeah.
Can we keep going? This is great. We're having a great time.
Oh, gee, pull up a chair. Did you bring your sleeping bag? Thank you so much, especially to everyone who dialed in. But thanks so much to Amy and Louise for dialing in from Sydney on our panel. We'll bring back up, giving us a wave goodbye there. Mike, you can come back to the full studio. Thanks very much to Ben Tran for coming in. And thanks for having me again. Thank you. Yeah, great to have you here. Ben's a long-standing supporter of the podcast as well. So you've been there since the very start, and thank you very much. And by the way, a cracking episode he did a few months ago about testis cancer with Rob Hamilton when he was here for the ANZAC meeting. So
that was great.
Thank you very much to you, Ben. Thank you for coming in.
Thank you.
And a special thanks to everyone at Mundipharma for putting this together, to Amber and Kieran for this idea of a webinar and for allowing us to say, oh, why don't we do a bit of a GUcast live event? And it's been fun.
It worked out nicely. It was really good fun. Great panel.
Yeah, and great to have the questions. Great interaction. I learned a bit. I learned a lot, actually.
I learned a lot.
Yeah.
I learned how to be more physicianly. Physicianly. Yes.
And that's it. And we will push this episode out as a podcast as well in the coming weeks. There will be a feedback survey that will appear on your screen. That's very important for us and for Mundipharma to learn from this, see what you enjoyed or didn't enjoy. We'd like to see more of this, hear more of this. We're very grateful to you for giving up some of your evening for joining us. That's all we have time for. I think we roll the shutters and Mike is going to play a video to get us out of here. But that's all from us here at GUcast.
Good night.